Hello everyone, hope you're all doing good. This is Dr. Agalya, your organic faculty. In this video, we are going to discuss about carcinoma ovary. Carcinoma ovary, I am going to start with history and examination because we should know how to proceed with the case of carcinoma ovary. And as we do the examination in history itself, we will be able to get some important points about carcinoma ovary, and then we will go into the theory discussion, right? Yes. So first, when you ask about history, usually the most common complaint the patient presents to you will be lump abdomen. Okay, the patient will be presenting a lump abdomen. You have to ask the duration of the mass, then symptoms, as well as if she has any associated symptoms also. And then you have to definitely ask about her menstrual history. Okay, usually the premenopausal females, will have no such complaints, and they can have complaints only in case of hormone producing tumors, especially the granular cell tumor and theca cell tumor. Suppose if she is a postmenopausal woman or menopausal age group woman, then you have to ask about the duration of menopause and if she has any history of postmenopausal bleeding. Then you have to ask about the obstetric history. So when you ask obstetric history, keep in mind the risk of ovarian cancer is going to be more in a case of nullipara. It is going to be more in a case of nullipara. Next, you have to ask about the contraception risk. So contraception, you have to know the intake of oral combined hormonal pills are going to reduce the risk of ovarian cancer. You have to ask about her past history as well. So any surgical history or medical history, treatment history like that. Then you will go on for family history, which is important again here. So there can be history of ovarian malignancy or any other carcinoma like breast carcinoma, endometrial cancer has to be elicited also, because any mutations that is involved in BRCA1 and BRCA2 which can involve these cancers can be linked with the person. The next one is her personal history as well. Studies show that women who consume more fatty diet are prone to get cancer ovary, as well as history of working in asbestos industry and cigarette smoking also increases the risk. Clear? Right. Now let us see how to examine a patient who comes with lump abdomen. So examination. First we'll start with general examination, where we will check if she has anemia, any signs of malnutrition, including cancer cachexia. As I told, breast cancer can be associated with certain syndromes. You have to also do breast examination, and during breast examination, you should keep one thing in mind. Either this can be a primary itself or this can be a metastatic ovarian tumor that has caused any lesions in the breast. Then you have to look for generalized lymphadenopathy and especially the left supraclavicular lymph node enlargement should be examined, right? Coming to gynecological examination, first we'll start with inspection, right? So while you do inspection, you have to look for the fullness of the abdomen first. Okay, so look for the fullness of the abdomen. Then you have to check if the flanks are full or not. Okay, in case of ascites, it looks equally full usually. Okay, this is a differential diagnosis, right? And in case of ovary involvement, there will be unequal enlargement. Okay, you have to also have a look over the skin, over the swelling. What about the umbilicus position, as well as you have to check for the presence of scar also. Clear? Right. Next is we'll do palpation, right? So when we do palpation, you'll be able to find a lower abdominal mass in case of CA ovary. Either it can be solid or cystic in part. Okay, that is partly solid and partly cystic, and the surface can be smooth or also nodular. Mobility is tested from side to side as well as below. Then you have to look for the lower border. In case of ovarian tumor, the lower border will be felt. Okay, so that is very important. And sometimes a long pedicle can also be felt. Okay, and suppose if there is ascites, you will be able to elicit fluid thrill. Yes, very good. You will be able to elicit fluid thrill, right? Next, you will do percussion, right? So when you do percussion, if there is ascites, you will be able to see the dullness on percussion, then shifting dullness will be positive, and yeah, fluid thrill can be elicited. Okay, you have to also do upper speculum examination for cervix and vagina inspection also. Okay, anyhow, per speculum examination and bimanual examination and all, final years are not allowed to do, but even then you have to tell them yes, it can be done. Okay, next is bimanual examination. You have to know the position of cervix, uterine size and mobility, and check if the mass is felt separately from the uterus or not. Because we know the ovary is situated somewhat distant from the uterus itself, right? So an ovarian mass will be seen distant from the uterus. If something is arising from the uterus means then it will be seen attached to the uterus, right? Yes. And next you have to also check through the fornices, okay, if anything is felt or not. You have to check for the size of the mass, consistency, tenderness, and check if the fornices are free or full, right? And next one is, you have to check for groove sign, if it is positive or not. Okay. So, groove sign is nothing but a groove that will be felt between the uterus and ovary. Clear? Now, let us discuss the differentiation between a fibroid and an ovarian tumor. Okay. So, this is important. So, fibroid usually occurs in the reproductive age, right? Whereas an ovarian tumor is seen in extremes of age. It can occur in young age also, or it can occur even after menopause, right? So, it is seen in extremes of age. And the second point is about the menstrual abnormalities. Yes. So, menstrual abnormalities or bleeding problems are common in case of fibroid. Okay. Whereas in case of ovarian tumor, that is not commonly seen. And the next complaint you will have is, you have to know that a fibroid is completely midline mass because it is going to arise from the uterus itself. Whereas ovarian tumor, either the right ovary can go for a tumor or left ovary can go for the tumor. Even if both ovaries goes for a tumor, definitely the mass is not midline. So, it is not a midline mass, right? And the consistency of fibroid is firm. Okay, F or F. So, firm consistency. And I already told you, ovarian tumor can be cystic or solid in consistency. And with fibroid, the mobility is not seen. Whereas in case of ovarian tumor, it will be movable in all directions. Yes, it is moved in all directions, right? And the next point is, I already told you, in case of fibroid, the lower border will not be felt. Okay, you won't be able to make the lower border because it will be arising just like that from the uterus. Okay, but in case of ovarian tumor, yes, you will be able to make out the lower border. So, lower border is not made out in case of fibroid, whereas it can be made out in case of ovarian tumor. Then, I spoke about groove sign. Okay, groove sign also the same thing. If the mass is arising from the uterus, means groove sign will be absent. Whereas in case of ovarian tumor, yes, the groove sign will be present because you will be able to make a groove between the uterus and the ovarian mass. Clear? Right. Now, I want to make another differentiating feature between a benign and a malignant ovarian mass. Okay, how you will be able to make it as a benign or a malignant mass while examining itself. Okay, so first, a benign mass is slow growing one, whereas a malignant mass is usually a fast growing mass. A benign mass consistency will be cystic and tense, okay, whereas in malignancy it will be firm and hard, right? So, this is the first feature, this is the second feature. And the next feature, usually benign masses are unilateral, whereas malignant masses are bilateral or unilateral. Okay, it can be both. Okay, and the next thing is, benign masses are usually mobile. Okay, they are usually mobile masses, whereas malignant masses are fixed masses. And in case of benign masses, you will have no ascites or there will not be any nodules in pouch of Douglas. Both are not present. Okay, whereas in case of malignancy, yes, ascites can be there and nodules can be felt through the pouch of Douglas also. Clear? Now, let's discuss about the differential diagnosis of mass abdomen. So, we have so many differentiating diagnoses. First one is ascites. I already told you, you will have shifting dullness here, right? So, there will be shifting dullness. Okay. That means what? If you ask the patient to lie on one side, the flanks will become resonant. Okay. Then, Second differential diagnosis is in-sister tuberculosis. Okay, tuberculosis features will be there like weight loss, evening rise of temperature, like that. Okay, and it can be a fibroid also. We have already seen the differentiation. Don't forget about a pregnancy. Okay, you have to check for the pregnancy signs as per histophemenorrhea, and while examining, you have to look for the fetal parts as well as fetal heart sound also. Then, full bladder. Okay, usually you can ask the patient to void once and come, or otherwise you can also catheterize and re-examine. Okay, to rule out this. Then, it can also be a functional ovarian cyst or a mass that is arising from the tube. For example, it can arise as a sequelae of pelvic inflammatory disease. There can be a large cyst also that is arising from ovary. So, the most common condition is, yes, endometriosis. Endometriosis, what we call the cyst that is occurring in ovary is, yes, the classical chocolate cyst, it is, right? Fine. Next one is, don't forget about this, it can be mesenteric cyst also. So, how you can identify mesenteric cyst? A mesenteric cyst is usually cystic in consistency. You have to check for the mobility. Okay. So, mobility is usually perpendicular to the mesenteric line. Clear? Right. The next one is, it can also be a renal lump or gastrointestinal lump. There can be splenic enlargement, or have to think about any surgical causes like a retroperitoneal mass, like a lipoma, lymphoma, etc. Clear? So, these differential features of mass abdomen is very important. It can be ascites, in-situ tuberculosis, fibrosis, pregnancy, full bladder, functional ovarian cyst, or a sequelae of pelvic inflammatory disease, chocolate cyst, that is endometriosis, mesenteric cyst, renal lump or gastrointestinal lump, splenic enlargement, as well as lipoma or lymphoma. Okay, so these differential diagnosis will be asked if you are given a mass abdomen question, right? Yes. Now, let's now discuss about ovarian cancer in detail. First, let us start with the risk factors for CA ovary. Okay, so risk factors for CA ovary will include early menarche, late menopause, or nulliparity, infertility, when there is prolonged use, okay, prolonged use of ovulation inducing drugs, there is an intake of high fat diet, and as I told you already, there can be family history also of endometrial, breast cancer, or even ovarian cancer. Okay, so that should be asked, right? Now, in that, let's discuss about hereditary non-polyposis colorectal cancer, okay, which is nothing but Lynch syndrome. So, in this syndrome, about 15% risk of CA ovary is there, and the genes involved here are the MLH1 and MSH2 and so many, but I am mentioning two of the important genes. And most commonly, you have to know the name itself is saying hereditary non-polyposis colorectal cancer. So, most commonly seen cancer is colorectal cancer, then it can be your endometrial cancer, then comes your CA ovary. Okay, so that's why I told you it is 15% risk to cause CA ovary, right? And the next one is BRCA mutations. Yes, BRCA mutations, both of them carries risk. Okay, either it can be BRCA1 or BRCA2. So here BRCA1 carries maximum risk up to 54% and BRCA2 causes 23% risk to cause CA ovary, right? And also know that hereditary ovarian cancer usually occur at a comparingly younger age. Okay, they occur comparingly younger age, whereas in case of sporadic ovarian cancer, they will occur comparingly at a older age. Clear? But yeah, either extremes of age are prone to get ovarian cancer, that is all. So if it happens in the younger age group, it is going to be hereditary ovarian cancer, and if it is happening in the older age group, it is going to be a sporadic ovarian cancer. That's it, right? Yeah. Now let us discuss about the etiology. So when we talk about the etiology, you have to know one important theory here, that is the theory of incessant ovulation. Okay, the theory of incessant ovulation. So what does this theory says? Okay, you have to know that the epithelial lining of ovary, okay, this may be sensitive to events like ovulation. Now, this can be a trigger to start the carcinogenic process. Okay, so this can act like a promoting factor to enhance the carcinogenic process as well. Okay, so a decreased incidence of ovarian cancer is seen with less frequent ovulation. So these benefits are noted when the patients who are taking oral contraceptive pills appear to have a low risk. Okay, and even after 10 years have passed after stopping the pills, the risk was persisting. Okay, so that is why oral contraceptive pills are found to be highly protective to prevent ovarian cancer, right? So that's why we say oral contraceptive pills has a beneficial effect to prevent ovarian cancer, right? Okay. Now, let's see how to screen ovarian cancer. Okay. So, screening of ovarian cancer. You have to understand that there is no routine standard method for screening. Okay. Like cervical cancer where we have pap smear, we can do colposcopy, HPV testing, like that. There is no standard method to screen ovarian cancer, right? And the detection can be needed in high risk women. So you can obtain history of family members if there was any ovarian cancer or breast cancer or endometrial cancer, like that. Then one thing you can do is, if they are telling yes, then you can go for BRCA1 and BRCA2 or even your Lynch gene screening. Okay, but this is not regularly applied because in India, because of the cost effective reasons, we will not be able to give this investigation for everyone, right? And another easy option is you can go for serum markers like CA125, but there is a risk again because CA125 is not specific, because it can be raised in many malignant as well as non-malignant conditions as well. Okay, now let us see some conditions where we can have elevations of CA125. So this will include both your gynecologic as well as non-gynecological conditions. So gynecological conditions will include acute pelvic inflammatory disease, adenomyosis, endometriosis, benign ovarian neoplasm, or even in case of functional ovarian cyst, It can be seen raised in Meigs syndrome, even during menstruation, also in cases of unexplained infertility and ovarian hyperstimulation. Okay, so these are some of the gynecological conditions where CA125 can be raised. And the next one is non-gynecological conditions. So these conditions will include acute hepatitis or pancreatitis, then conditions like cirrhosis, chronic liver disease, colitis, congestive heart failure, diabetes, especially when it is underly controlled, poorly controlled, then diverticulitis, pericarditis, pneumonia, likewise. Okay, so etc. So many conditions you have. These are some of the conditions where CA125 can be raised, right? So after offering CA125 and knowing that this is not going to be specific one, what other investigation you can offer them? Yes, you can offer them transvaginal sonography directly. Yes, you can visualize any lesions if present. And then number 2 you can do is pelvic examinations. Okay, direct pelvic examination. I want to discuss about 2 important scores with which we'll be able to rule out whether it is a benign or ovarian cancer. Okay, so that is, we have ROCA, that is risk of ovarian algorithm. Okay, so this is usually done in a case of postmenopausal women, where will be using her age, CA125 values and pelvic USG. Either it can be a transabdominal scan or a transvaginal scan. These things can be used, right? And the next one is ROMA. ROMA means it is risk of ovarian malignancy algorithm. Okay, risk of ovarian malignancy algorithm. Now this is based on markers like HE4, CA125, and here also we will be checking the menopausal status of the female. Clear? So these are the 2 methods. Now let's discuss about the histologic classification of ovarian neoplasm, right? So when we discuss about the histologic classification of ovarian neoplasm, the neoplasm can be either derived from coelomic epithelium of ovary, or it could have been derived from germ cells, right? And also there is a chance that it can be arising from the specialized gonadal stroma. There can be tumors which are arising from non-specific mesenchyme, and there can be metastatic tumors to the ovary, right? So these are the possibilities. Now let us learn what are these tumors. Okay, so the tumors that are arising from coelomic epithelium will include your serous, mucinous, endometrioid, Brenner, undifferentiated tumor, like that. Okay, even you can consider your mesonephroid tumor here. Okay, so these are the tumors arising from the coelomic epithelium. And the next one is tumors that are arising from the germ cells. Okay, So this will include your teratoma, that can be a mature teratoma or a solid or a cystic teratoma, like that. Even your dermoid cyst, okay, all those come under this germ cell tumors. It can be a struma ovary. Struma ovary is nothing but a dermoid cyst which has more of the thyroid tissue, so that it will be acting, that is more of hyperthyroid activity will be seen. Okay. Then malignant lesions that are arising secondary from the mature cystic teratoma, and tumors like dysgerminoma, embryonal carcinoma, endodermal sinus tumor, choriocarcinoma, gonadoblastoma. Okay. The next one is tumor that is derived from the specialized gonadal stroma, that will include granulosa, theca cell tumor, then granulosa tumor itself, or it can be Sertoli Leydig cell tumor, your arachnoblastoma, then gynandroblastoma, and also your lipid cell tumors. Okay. The tumors that are arising from non-specific mesenchyme means that will include your fibroma, hemangioma, lipoma, leiomyoma, lymphoma, or even sarcoma. Okay. Then tumors that can metastasize to ovary. So this can arise from, already we have seen breast, endometrium. Okay. Some of the tumors can even metastasize from the gastrointestinal tract. Then it will be called as Krukenberg tumors, and also, yeah, lymphoma can also metastasize to the ovaries, right? Now I am not going to discuss in detail about each and every ovarian tumor. I am going to give you a hint on the importance of various tumors only. Okay, yes. Now in this video we are going to discuss about epithelial ovarian cancer alone. Okay, so in the next part we will do the other types of tumors, right? Now epithelial ovarian cancer. Epithelial ovarian cancer constitutes about 90 to 95% of the ovarian malignancies, and you have the malignant germ cell tumors and the sex cord stromal cell tumors, whatever, that will be making only less than 5% of the cases. Okay, so that's why this epithelial ovarian tumor is very important, right? And the next one, the peak incidence of invasive epithelial ovarian cancer is about 60 years of age, and only 1% of tumors can be seen in young age group, and in young age group the most common group of cancers that can occur is germ cell tumors. Clear? So it is epithelial ovarian cancers which is making 90 to 95% of the ovarian cancers. Less than 1% only is made by the sex cord stromal cell tumor as well as the germ cell tumors, and epithelial ovarian cancers are usually seen above 60 years of age, and only less than 1% of the tumors are seen in younger age, and in that most of the tumors are germ cell tumors. Clear? Yes. Now let's start talking about ovarian cancer as it is. Okay, so ovarian cancer is the second most common gynecologic malignancy. Okay, especially in India. So, which is the first gynecological malignancy? Yes, it is going to be CA cervix. Now, it is also the fifth most common malignancy in women. Okay, so considering other tumors like breast carcinoma, lung tumors like that. Okay, and a woman's lifetime risk of detecting with ovarian cancer is going to be 1 to 1.5%, and the chance of dying from ovarian cancer is going to be almost 0.5%. Clear? Now, let's start discussing about each type of epithelial ovarian cancer. First, it is going to be a serous adenocarcinoma. Serous adenocarcinoma. So, this is the most common variety and it makes about more than 50% of all ovarian cancer itself. Okay, so more than 50% of the cancers are serous adenocarcinoma. It can be of low grade or high grade. So, if you see low grade type, these are usually characterized by well differentiated pattern that is resembling epithelium of fallopian tube. Okay, whereas the high grade tumors are characterized by solid sheets of cells there will be nuclear pleomorphism, mitotic activity. Also, sarcoma bodies are seen in 80% of the cases, and these are pathognomic for serous carcinomas, right? Next type is mucinous carcinoma. So, mucinous carcinoma or mucinous adenocarcinoma, these are confined to ovary in 95 to 98% of the cases. They are confined to ovary and it is going to be bilateral in 8 to 10% of the cases, and mostly they will contain enteric cell type. Okay, enteric cell types. So, it will be difficult to differentiate it from metastatic carcinomas, right? So, one thing you have to know here is pseudomyxoma peritoneum. Okay, pseudomyxoma peritoneum. So, here you will have abundant of mucoid or gelatinous material that is present in the pelvic cavity or abdominal cavity, and it will be surrounded by a fibrous tissue. Okay, and the most common cause for pseudomyxoma peritoneum is going to be a well differentiated appendiceal mucinous neoplasm, or it can be mucinous cystadenoma of ovary. Okay, but in this case the recurrence is common. You have to know the recurrence is common. Also, the prognosis is bad because there can be chances of incomplete removal. Because why? This is like a gelatinous material, right? So, removing it completely will be difficult, right? So, what you have to do is always you have to do appendicectomy and histopathological examination of appendix is also to be done. Clear? Now let's discuss about endometrioid carcinoma. Okay. The next type is endometrioid carcinoma. So endometrioid carcinoma is the second most common variety. What is the first most common variety we have seen? It is the serous serous adenocarcinoma. So endometrioid is the second most common variety, and it demonstrates, from the name itself you will be able to know that it demonstrates features of endometriosis. Okay, endometriosis features are seen. Okay, and also you have some malignant potential, but it is only very low. Okay, but the transition can over from ovarian endometriosis also. Okay, then it will be associated with endometrial adenocarcinoma also in about 15 to 20% of the cases. Okay, so if it is associated with endometrial adenocarcinoma, then it will be known as a synchronous tumor. Synchronous means a tumor that is occurring at the same time in two different places, right? So one is endometrial adenocarcinoma and another one is your endometrioid carcinoma. Clear? Right. Now coming to clear cell carcinomas. So clear cell carcinomas, this is also mostly associated with pelvic endometriosis, and here the tumors are made up of clear and hobnail cell that project their nuclei into their cytoplasm. So this is a characteristic finding which can be asked in exams. Okay, with the hobnail cell appearance means you have to think about clear cell carcinoma, right? And so what do you have here? You have a clear cell here with abundant vacuolated cytoplasm, and there is also hyperchromatic irregular nuclei. Okay, and you have to know the nuclei grade is higher. Okay, these nuclei have a higher grade. Clear? Now coming to Brenner tumor. See, Brenner tumor can be benign or malignant. Here we are going to discuss about the malignant Brenner tumor. Okay, Brenner tumor. So these are some of the rare tumors, and it can coexist with transitional cell carcinoma, right? Yes. Now let's discuss about the staging now. When we speak about the staging, the primary sites considered in this staging are three places. Okay, so one is your ovary, the other one is your fallopian tube, and another one is your peritoneum. Okay, so these are the three primary sites that are considered in this classification. So in 2014, the FIGO staging, they incorporated all these three things under CA ovarian cancer. Okay, so why this consideration was made? Because they found that some of the high grade ovarian neoplasms or even some high grade peritoneal neoplasms had origin from the fimbriae of tubes. I hope you can think about the anatomy of tubes. Okay, so that's why all these three are together in staging. But whenever it is possible for you to make any separate site of origin of carcinoma, then you can designate it Otherwise, it can be written as undesignated. That is, you are not able to make out which is the primary site among these three. Clear? Okay, now let's see the staging of ovarian cancer. Let's see this pic first and get a rough idea of how the stages are divided. Then we go for a detailed explanation and come back here again, right? Now, so first is the tumor is limited to the ovaries only. Okay, you see the dark blue thing is the tumor that is in the ovaries only. Okay, in stage 2 what happens means the tumors will involve the ovaries or even the fallopian tubes, but there can be some pelvic extension also, or there can be peritoneal cancer, right? That is stage 2. And in stage 3, there is nodal involvement. You have positive retroperitoneal lymph nodes or pelvic lymph nodes like that. Okay, so that is stage 3. And there can be involvement of the opposite fallopian tubes also, right? That's what we see here, right? And the next one is fourth one, we have distant metastasis. That is clear like other carcinomas. Okay. Now let's discuss Figo staging of the ovarian, fallopian tube and the peritoneal cancer. See, stage 1 is where the tumor is confined to the ovary or the fallopian tubes. Stage 2 is where it involves both the ovaries or fallopian tubes, but there is pelvic extension and it also may be a peritoneal cancer. Stage 3 is where it involves one or both ovaries or it can be peritoneal cancer, and the spread can be to the outside of the pelvis also, and there can be lymph nodal involvement, especially the retroperitoneal lymph node involvement. Stage 4 is something distant metastasis that should exclude peritoneal metastasis because we are involving peritoneal metastasis in stage 3. Clear? Right. Now, what is 1A? Okay, first stage is further divided into 3 stages. 1A is tumor limited to only one ovary. Remember, here the capsule is intact. When the capsule is intact and it is limited to one ovary, you have to rule out any carcinoma that is present in the fallopian tube or the peritoneum. Then only you will be putting the carcinoma in stage 1A. Okay. Stage 1B means the tumor will be limited to both ovaries, but capsule intact. Here also you have to rule out any tumor that is present in the fallopian tube or in the peritoneum, right? Then stage 1C is the capsule is going for a spill. How a capsule can go for a spill? You are doing a surgery for the patient and at the time of surgery there can be a spill. You only initiated it, so it will be 1C1. And 1C2 is something before surgery itself. You see the capsule would have ruptured. You didn't do anything, but there was a rupture. So you upgrade the stage and give it as 1C2. Stage 1C3 means the capsule would have ruptured already long before. You don't know or the patient also don't know. But what would have happened? The cancer cells would be found in the ascites or when you take a peritoneal washings during surgery. Clear? So you just upgrade the stage. That's it. 1C1, 1C2, 1C3. There should be no confusion here, right? Now coming to stage 2. Here the tumor is involving below the pelvic brim, anywhere below the pelvic brim, and it can be also a peritoneal cancer. Okay, so it is further divided into 2A and 2B. 2A is extension or implants on the uterus or fallopian tubes or ovaries. Okay, so the extension is of the cancer is going to the fallopian tube or the uterus or even the ovaries, and the extension to other lymphatic, other pelvic intraperitoneal tissues is 2B. Okay, other intraperitoneal tissues is 2B, right? Next is stage 3. Already I told you what is stage 3. Outside the pelvis it is coming and retroperitoneal lymph node involvement. So it is further divided into 3A, 3B and 3C. 3A we are further dividing into 3A1 and 3A2. It is nothing about the lymph node involvement. Okay, so you have positive retroperitoneal lymph nodes only, and in 3A2 you have microscopic extrapelvic peritoneal involvement with or without positive retroperitoneal lymph nodes. Okay, so 3A1 and 3A2 are not interrelated. Remember, 3A1 is positive retroperitoneal lymph nodes. Again, 3A1 is divided into 2 subdivisions where one is up to 10 millimeter metastasis and another one is more than 10 millimeter metastasis. Okay, 3A2 is about involvement of extrapelvic sites, okay, above the peritoneal involvement. there can be positive retroperitoneal lymph nodes or not. Retroperitoneal lymph nodes, even if positive or not positive, you are not worried. But whenever there is extra pelvic peritoneal involvement, you are going to keep it under stage 3A2. Clear? Right. Now coming to stage 3B, here the past two stages, that is 3A1 and 3A2, are microscopic. Whereas coming to 3B, it is a macroscopic stage where macroscopic lesion, where macroscopic peritoneal, repeating once again, see in stage